Good morning, everyone. Thanks to the organizers for inviting me to this very nice session. So I'm going to talk about molecular diagnostics in the pneumonia pathway. And there's a lot of this, obviously. So what I'm going to do is really just talk about the most common ones and maybe the one that you're going to encounter most likely in your clinics, which is right now, I think biofire is what a lot of people are seeing. But we'll talk a little bit about the other panels as well. So our objectives are really just want to know about what we have available and also how these actually fit into our use cases, because these are expensive panels, we know that, but what is the best way to use them so that we can improve our outcomes and also be cost effective at the same time. So when we talk about molecular diagnostics panel, this is a relatively new field. When I was in residency, I won't tell you when, but at that time we had all these lab homebrews that the labs themselves were making. I was doing mine at the Medical College of Wisconsin, and they had something called a hexaplex panel, which was basically 6 viruses. It was a multiplex PCR, and there have been all sorts of panels, including antibody, antigen panels, but right now we're just really going to talk about nucleic acids, multiple pathogens from respiratory specimens. We know there's also a whole bunch of other molecular panels for blood, for even joint infection, CSF, gastrointestinal, but because this is PCCP, we'll focus on the lungs and the respiratory system. This is a tricky slide to digest, because the problem is this is a moving target. When you talk about what the different pathogens that cause community-acquired pneumonia are, it also depends on what diagnostics you're using. Obviously, if you're only using culture, you're not gonna find very many viruses. But if you're using molecular diagnostics panel, then you're gonna find a lot of viruses. But the interesting thing about this particular study is that when they did this study, they didn't find any in about 60% of the patients. And that's pretty much similar to what they found both in USA and in Europe, except that in the United States, they actually found more viruses. And in Europe, they found more bacteria. But this is also probably a result of how many molecular panels they were using in the US versus how many molecular panels they were using in Europe. But in general, for atypical pathogens as well, this is going to look very different depending on how you test. But nevertheless, we understand that a lot more of these community-acquired pneumonias are being diagnosed as viral pneumonias. So why are molecular diagnostic panels useful? So first of all, there's a quick turnaround time for identifying a pathogen. For instance, for blood cultures in particular, you can actually have the pathogen and even some of the resistance mechanisms available 2-3 days before you get the final culture. Because once the blood culture becomes positive, say it says gram-positive cocci, it'll take 2 to 3 days before you do the ID and the sensitivity. But your panel can already flag if it's Staph aureus and whether it's MEK-A positive, which means it would be MRSA. So that's useful information. For respiratory and for pneumonia panels, you can do what's called metagenomics. When you say metagenomics, you're actually doing it off the specimen directly, as opposed to doing it on a culture. So when I talked about the blood culture, usually you need to have a positive blood culture and you do that test on the culture, so that still takes about 2 to 3 days for the culture to become positive. When you're doing metagenomics, you're getting it directly off the specimen, so you can get a result in 2 to 3 hours. So that's very, very useful. And you can identify multiple pathogens, and this is interesting because when in medicine, we like serendipity, we like being parsimonious, and so we try to explain everything with one reason. But the interesting thing is we're seeing more and more co-infections. I know during the pandemic, people were talking about stuff like Flurona, right? Which is really just a co-infection between influenza and COVID. And that happens precisely because these are viruses that are transmitted the same way. For sexually transmitted infections, we always say, you know, if you have one STI, you probably have to think about others. So it's not a paradigm that we're used to when we're talking about respiratory infections. But because we have these panels, we're starting to see, even taking into account, you know, colonizers or something like that, that there are subsets of infections that really are co-infections or super infections. So obviously, for those that are unculturable, like atypical pathogens or very hard to culture ones, you're going to get an answer. It can identify resistance genes. In this day and age where we have so much ESBLs, carbapenem resistance, this can be very, very useful in picking the antibiotic that you're going to give. So if you have a Staph aureus and SMEC A positive, you already know to add the vancomycin 2 to 3 days before you're going to see that culture come out. And for stewardship, obviously if you have somebody with pneumonia and you do the test and it comes out influenza, then you probably don't need to do the ceftriaxone azithromycin, right? Although some of us are not so brave, especially when you look at the x-ray and it still looks like a bacterial pneumonia. But I think that's going to change as more and more people become comfortable with the results of these. Whoops, what's going on here? Sorry, I think we, oh, sorry. Okay, so this quick turnaround time, again, multiple pathogens, I guess it didn't work, the animation. So what are the disadvantages? So let's talk about those. It's expensive, obviously. Requires a sophisticated laboratory. So BioFire is a big 5 million peso machine. If some of you are Gene Expert, as you know, we can use multiplex panels on Gene Experts, but particularly for, in fact, there is an RSV influenza coronavirus cartridge. You know, those are still expensive. And you need a laboratory. But with the cartridge-based tests, you know, it becomes a lot easier compared to having to do the PCRs that we used to do with the PrEP. So false positives, and I think a lot of people understood this during the pandemic, that because these are nucleic acid tests, that you can detect residual virus or bacteria even after the patient has already recovered. False negatives, if you have improper collection, you don't process it immediately, or there are some inhibitors in the specimen. And of course, if you only think about the positive test and not the clinical situation, then it can really mislead you. So we have to correlate all these tests clinically. Is it contamination? Is it colonization? Or is it a true pathogen? Because a lot of these are also normal respiratory flora. And the nice thing is that some of these panels will actually give you a quantitative measure of some of the bacteria. Say if you grow Acinetobacter baumannii, you grow Haemophilus, or not grow, detect those, it'll actually tell you how much in terms of a semi-quantitative state, so that you can make a decision, okay, which one's the player? Is it the Haemophilus? Is it the Acinetobacter? So again, you can do it directly on the specimen, or you can isolate the bacteria first, and then you can do the test on that. Now, the advantage of isolating it first is more or less, you know, you have a pure culture. And you're also more likely to detect resistance genes when you have a lot of the bacteria on board. So there are advantages. But obviously with metagenomics, you get your answer you know, in 2 to 3 hours, and the patient's still in the emergency room, and you already have an idea of what's going on. So direct specimen detection shortens time to identification and correct diagnosis, but isolate-based detection will tell you what bacteria, but you can still confirm it with a culture once this culture and sensitivity are done, and you can detect the common resistance genes. So let's talk about some of the respiratory panels. The very first ones, like the hexaplex I told you about, these were laboratory-developed tests, and interestingly, in the United States, the FDA does recognize these, although they're starting to crack down, and that's a concern because it's part of the evolution of making tests that the laboratories put together these kits or these panels, and eventually they will become FDA cleared. But for instance, with COVID, a lot of the original tests were really put together, home brews, and then they became licensed. This is just RSV that I talked about when I was in residency. Hexaplex. And then multiple respiratory panels are also developed by other labs. Now, the problem with proprietary panels is that they're very difficult to, you have to send them to a different lab, and they have very specific requirements, and it may or may not be all that sensitive or specific. Now, so those are just the home brews. Okay, let me see. So, commercial respiratory panels have been developed as all-in-one systems that are self-contained, and these are the easier ones to use, either the cartridge-based ones or the pack-based ones, just like the BioFire ones. The problem is that sometimes you have to buy the machine as well, and those are expensive. And for metagenomic detection, they use pathogen-specific primers with tags, and they can detect multiple pathogens from the same specimen. So that's one of the huge advantages. These are near point-of-care assays with multiple targets, turnaround time in a few hours. And the most comprehensive panels, if you really want to get to it, can actually detect hundreds of pathogens and genes, actually even thousands, but these are not for clinical use. This is what the CDC uses when there's an unknown pathogen, and they just run it through there, and they'll test it for 5,000 things. Those are really cool, but they're very expensive. And so these are what we call syndrome panels for diagnosis of community-acquired pneumonia. There's a whole bunch of these. I'm not going to go through all of them, but I think the most familiar to us are the BioFires that are present here. But these are all there. Well, there's a gene expert here, SARS-CoV, flu, RSV at the same time. So you get 3 viruses. And then you have these are the specimens for the most part. So for viral, you usually get better results if you're getting it off a swab. And obviously for pneumonia panels, you either use sputum or you use a BAL. This is the this is the one that can detect thousands of pathogens, and these take a while. So you can see there's 180 bacteria, 40 viruses, 50 fungi, 2,000 AMR alleles with predicted resistance. So these are pretty cool, but you'll probably not be using them unless you work in detection, in surveillance, or you're doing some research. So let's talk about the BioFire panel, because this is the most, BioFire is not paying me to talk about this, but these are the ones that, how many of you guys have used BioFire? I'm just curious, whether it's a RESPI panel or just what about any other molecular panel other than Gene Expert? Because everybody's used Gene Expert here. Do your hospitals have anything else that's no? So I think BioFire is the most popular right now, and it uses a film array platform. Turnaround time is less than an hour. Respiratory panel specimen is nasopharyngeal swab. Pneumonia panel uses sputum, BAL, or a tracheal aspirate. And then these are little pouches that you stick into the machine, self-contained. They do multiplex PCR, nested PCR, and also melt curve analysis. So this is what the respiratory panel menu looks like, and you can see virus, 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 and atypical pathogens. For the pneumonia panel, these are semi-quantitative, and this is what I told you about. It'll tell you, because a lot of these are colonizers, so it'll tell you what, you probably sometimes have to ask the lab because they'll just report it as positive, but they'll tell you if it's 10 to the 5th, 10 to the 6th, 10 to the 7th, and you can kind of compare which is the predominant organism. And then atypical bacteria are over here, viruses are over here, and these are cool, antimicrobial resistance genes. So if you see maybe KPC, then you know you're going to give ceftaz-avi. If you see NDM, you might have to give ceftaz-avi plus estrionam. So those are really useful. If you see a CTXM, then instead of ceftriaxone, maybe you should start with a carbapenem. So here's a use case. 67-year-old male with diabetes, COPD, with recurrent hospitalizations, admitted to your hospital for community-acquired pneumonia, moderate risk, patient started on ceftriaxone and azithromycin. Initially, he does well, and then on the third hospital day, develops fever with increasing dyspnea and decreased O2 saturation. Chest X-ray shows a new right lower lobe infiltrate. Patient is intubated, transferred to the ICU, shifted to piperacillin tazobactam, and the sputum gram stain shows gram-negative bacilli. So the pneumonia panel is done, and it's positive for Klebsiella and positive for CTXM, which is also positive, CTXM gene also positive for KPC. So it's like both, unfortunately. So at this point, instead of continuing the piperacillin tazobactam, which is not very good for CTXM, but even worse for KPC, then the patient, you already got that information ahead of time. It would have otherwise taken 2 to 3 days, and the patient could have died in the meantime if you just continued the piperacillin tazobactam, because this is a carbapenem-resistant Klebsiella, which I think more and more of us are seeing. How many of you guys have seen carbapenem-resistant Klebsiellas in your patients? Not see too many. There's some. In PGH, it's maybe 25%. ARSP says about 10 to 11%. So you're going to see it if you haven't seen it yet. But the important thing about carbapenem-resistant Klebsiella is that there are different resistance genes, and those include NDM, KPC, OXA48, IMP, VIM, and there's an important distinction between KPC and NDM, because KPC you can treat with ceftaz-avi, NDM you need to combine the ceftaz-avi with aztreonam, otherwise your patient is at high risk for failure. And this is why these panels are going to become very, very important later on. So if somebody has a carbapenem-resistant Klebsiella, that's not enough. You have to figure out whether it's NDM or KPC. We're doing a study now in PGH where we're actually using not BioFire, but a different platform, GeneXpert CarbaR, which actually looks at those different carbapenem resistance genes, and we're showing maybe 70% of them are NDM. About 15% are KPC, and the others, they're mixed. Some of them have NDM and OXA at the same time. Some of them have KPC and OXA at the same time. It's kind of interesting, but the bottom line is about 70 to 80% of our carbapenem-resistant Klebsiellas in the Philippines are probably NDM. So this is going to help, because if it's KPC, then you can save money by not having to add the aztreonam. But if it's NDM and you don't add the aztreonam, your patient might not get better. So the patient improves and is extubated. Final culture grows Klebsiella pneumonia, which is susceptible to ceftaz-avi and amikacin. I would not advise using amikacin here because aside from the fact it's a very resistant organism, amikacin only gets about 30% of your levels in the lungs, so it's not ideal. Intermediate to colistin, resistant to meropenem, piperacillin, tazobactam, and cefepime. And so the take-home point here, we had early treatment of CRE, which would otherwise have been delayed without the pneumonia panel. And if this was NDM, then we would have had to add aztreonam also. So this is kind of the future when we start to see patients who have carbapenem-resistant Enterobacteriaceae, particularly Klebsiella. All right, so in summary, syndromic approach to disease using multiplex panels is useful for arriving at a diagnosis. Whether it's worth the money or not, it really depends. Respiratory panels and pneumonia panels offer rapid etiologic diagnosis and can detect unculturable or hard-to-culture pathogens. Results still need to be taken in the context of the clinical disease, because we still have patients, we can have false positives from people who have already recovered, and those could just be residual nucleic acid material, or they could be colonizers. Ability to detect resistance genes increases the chances of early definitive treatment in light of increasing gram-negative resistance. In the Philippines, our ESBL rate is 56%. Not all of those are CTXM, maybe 60, 70% are CTXM. So you'll detect a CTXM, but that doesn't rule out an ESBL. Cost of the panels is currently a limiting factor, but this is going to come down as more and more of us become used to it. Right now, I think respiratory panels, the cheapest I've seen are maybe 8 to 10,000, and pneumonia panels are about 18,000. So they are expensive. Multiplex panels will become increasingly more common and a useful tool for improving patient care and for antimicrobial stewardship as well. So thank you very much.